Hey guys, just a reminder, this is not official medical advice or such. Please seek an appointment with a licensed medical provider.
Hi, this is Dr. Tom Rogers coming to you with another weekly episode of the Common Sense MD. Today I have a very special guest. He's a PharmD, which means he's a doctor of pharmacy. His name is Vinay Patel. Now, I've worked with a lot of Patels through my life, and they had one thing in common. They're all very smart. So, and he certainly is too. In my previous conversation with you today, this is really the first time we've met. I had seen some of your blogs, and you're very entrepreneurial. You're in the functional side of medicine, but your main deal, I think, and we'll talk about it, is why, how do you get your drugs and your pharmaceuticals affordable? Because as you know, and as I know from practicing medicine for so many years, what's happening with our pricing in medicine is just ridiculous.
Yes. Yes.
I'll lead in with one example because this is so pertinent to this. A couple weeks ago, a guy drove down 100 miles to see me, and he has narcolepsy. So of course, I'm gonna try him on modafinil, which is a good drug for that. I've had success with it in the past. So he drives back to Knoxville, goes to his local CVS, and calls me back that afternoon. He says, I cannot afford this medicine. It's going to cost me $750 a month. Well, I was shocked. So I said, he was at the pharmacy. So I said, put the pharmacist on. Let me talk to him. And so I said, is this generic Provisial called modafinil costs $750 a month? And he goes, yeah, that's our price on it. So I told the patient, let me hold off on getting that filled. Let me call around. So my nurses called around for me, and we found with GoodRx at Food City, he gets it for $35 a month. So in other words, somebody's ripping somebody off here. Let's riff about this a little bit because that just bothers me. Somebody's really getting ripped off. The other thing I do not like are the PBMs, the pharmacy benefit managers.
Yeah.
I think they're soaking up a lot of the profit from pharmacies and even pharmaceutical companies. So we'll talk about this a little bit. First of all, tell me a little bit about yourself, your background, and what your goals for your business are.
Yeah, absolutely. Dr. Rogers, first and foremost, thank you so much for the opportunity. It's an honor to be here on your podcast. And as you mentioned earlier when we were talking, you haven't missed a beat. Every week you've been getting this episode out. So thank you so much for the opportunity. So my background, as you mentioned, I'm a pharmacist. I've been a pharmacist for close to 20 years now, worked in various different areas of pharmacy, whether it be academia, teaching pharmacy students and medical residents and medical students and pharmacy students, or whether it be working for the University Medical Center. And we set up a pharmacy program for the medical center for the university, worked in health systems and independent physician practices, similar to the ones that you've set up, Dr. Rogers, and we've set up pharmacy services inside of them to help support the care that clinicians provide. And it takes a team to take care of a patient. Worked in independent pharmacies, worked in home delivery pharmacies, and seen just a lot of different aspects of pharmacy. But to the point that you made, it's just like in medicine, the insurance companies follow you around like a shadow. In pharmacy, these pharmacy benefit companies get to dictate what you tell patients sometimes, or how much money you'll make, or how to care for your patient, what medicines they're allowed to have. And it's really, we saw it as a growing problem, in particular to the affordability of medicines, to your point of an example as well. And so we set up this company called MakoRx as a cost-plus pharmacy benefit solution, particularly for employer groups, to make hardworking folks that spend a lot of time working for companies all over the country, but particularly here in North Carolina, find ways to make medicines more affordable. And that's through our cost plus network of pharmacies, mostly mom and pop pharmacies. We do have grocer networks in our pharmacy as well. And that's about 20,000 pharmacies across the country where you can access our cost plus model.
Wow, I love the cost plus model. When you mention that, automatically my mind goes to Mark Cuban for some reason. But is it a similar model that Mark Cuban has?
Yes, a couple of things about Mark Cuban. I think he's trying to earnestly trying to solve a really hard problem in healthcare, and we need more people like him and like yourself, Dr. Rogers, more entrepreneurial people in healthcare that are trying to solve these hard problems. And to answer your question, our model is similar. It's the difference is Mark Cuban has a mail order pharmacy out of Dallas, Texas, that he sends all the medicines out to wherever people live in the country, versus us, you can access the same cost plus model at local pharmacies all over the country. And that's sort of the difference, is that we want to encourage people to go into their local mom and pop pharmacies, to have a relationship with them, to see the difference in care and the quality of care and the customer service you can get from a local hometown pharmacy, which many people we talk to every day have forgotten that they exist because they think they just went out of business, and they think that the big shiny chain stores are the ones that you got to go to because that's what the insurance companies tell you to do.
I love that. I really love that. I love the independent pharmacies over the big chains. I just mentioned one of them. The other one you'll know, of course. But yeah, you just get such impersonal care. And that's one reason I went on my own because, I practiced for a hospital group and then a large group. It's just not as personal. And I mean, think about it. Going up to your trusted pharmacist, I think patients trust the pharmacist more than they trust the doctor nowadays. There's no doubt about it. If you look at the list, I think that's pretty true. So I encourage my patients not to go to the big boxes. Find you a local pharmacy, which we have many,
Yeah.
because you'll get to know the pharmacist and their staff.
Let
They'll take care of you. They'll explain to you what,
Yes.
hey, I know your medicine list. You need to worry about this, not that. Same thing really with a lot of these mail order um, or call in telemedicine practices. I myself do some telemedicine, but it's on a more personalized basis than, say, Hims or Hers or Roe. I mean, when you're prescribing somebody a hormone or a medicine for that type of thing, our gig really is a lot of hormonal stuff. That's my expertise, and metabolic syndrome. But are you getting your semiglutide through the mail? You may talk for 10 minutes to somebody that you don't even know who he or she is, and you probably won't talk to them the next time. So there's a fall off in patient care with this stuff. I mean, I think telemedicine is good. We did a ton of it during COVID, treated a lot of COVID patients over the phone. But now you have all these things popping up everywhere that it's easy. Just dial in this number. We'll take care of you. We'll send you your Viagra, your Cialis, or maybe even your testosterone. But there's a lot more to it when you're treating a patient. You're looking at everything. They have
Yeah.
low T. Well, you may have heart disease too. Have you
Yeah.
looked at your insulin resistance numbers?
That's
What
right.
do you weigh? What do you eat? These are all things I like to address. More of a holistic way of practicing, meaning the whole body. So same thing with probably Mark Cuban or some of these other things, these mail order pharmacies. I think I saw a statistic last week in the Wall Street Journal. Correct me if I'm wrong, but some of the mail order pharmacies um, that are associated with the pharmacy benefit managers, they control about 66% of the prescription in this country. Is that true? Is it anywhere near there?
So you're close. The largest pharmacy benefit companies, the three largest pharmacy benefit companies in the country control 80% of all the prescriptions. It's crazy.
Is
It's
that
absolutely
sad?
crazy. I know. It's crazy to think that there's just three institutions in this country, this great land of America, that promotes entrepreneurialism and competition. That we have three entities that sort of dictate all of healthcare on the pharmacy side.
What the fact that CVS did not like dealing with the PBM, so they just bought their own. I don't see how that's legal, but they bought their own. It's interesting because our congressman, this congresswoman from our district here, we're very good friends. I've done a podcast if you want to go back and look at it. Diana Harshbarger, she's a pharmacist, a compounding pharmacist that I've worked with for many years. So she's in Washington now. So she had an event this summer in my hometown, Kingsport, Tennessee, where she had Jim Jordan. with her. He's big in the Republican Party, and has a lot to do with influence. And so I met him, and all I told him was, "Hey, you've got to do something about these PBMs," and he agreed. And as a matter of fact, Diana Harshbarger was in the Wall Street Journal last week. She's just brought up a bill that is going after them, and I think they should be shut down. I really do. I really do.
I have a different perspective. I think that they should be broken up so that they can play on the same level playing field that everyone else has to play on, and we just compete against, like we always have wanted to, which is quality and service. If you can compete on quality and service and you can't just beat someone with a big check or an extra rebate, then I think that creates a lot more accessibility and innovation. When you have competition, you have a lot more innovation than when you have monopolies or oligopolies running, parts of an industry. And we're not alone. Healthcare is not alone. These monopolies exist in almost every sector of American life. And it's crazy to think that, what happens? The only difference is in healthcare, you're dealing with people's lives. So it's not the same as, some other service or product that you may provide.
No, it's not like selling hamburgers or, producing oil. As a matter of fact, the healthcare industry is by far the biggest industry in our country, by far.
That's right.
Over the oil companies, over the Apples, over anything. The healthcare industry is the biggest there is. And unfortunately, in my opinion, it's kind of been hijacked. And, like me, old-fashioned family doctor, you just don't see much of that anymore. It's more like, everybody's on a cookbook formula. That's the guidelines. That's what we have to do. We'll get dinged if we don't do this. So fortunately, I'm able to do what I want to do for the patient. My only concern is the patient. Talk to me about why that happened at CVS. Well, their price was $750 for 1 month of modafinil, and Food City, under the program GoodRx, was able to do it for $35 a month. How can that possibly happen?
So it's a funny thing. GoodRx actually works with Caremark and Express Scripts and OptumRx in the back end. They have these what's called contract riders. So they work with these big PBMs to say, if a patient can't afford their medication because they're on a high deductible plan or they don't have any insurance, so they got to pay cash, we're going to offer a discounted price that doesn't interfere with any of the agreements you have with the pharmacies or with any of your with any of the people that use your insurance services. We're going to be outside of that, and this is going to be an addition to that, so that when they use this GoodRx card, it's essentially a cash discount on the price. But at the end of the day, what's really interesting or eye-opening for people is that GoodRx hurts pharmacies, particularly the mom and pop pharmacies. I know about the pain scores and the deal that they can have with these grocery networks, but the reimbursement that GoodRx essentially takes, in certain instances, can take up to half of the cost of that drug as a clawback to GoodRx, and then they share it with the big insurance companies or pharmacy benefit companies that they're using these contracts with. And so at the end of the day, for some medicines, it can hurt the pharmacy because they're getting paid less than what it costs them to buy it. And so then, now we have, so that's the difference here, is that when you go up to a pharmacy and say you want, especially a big national pharmacy, chain store pharmacy, you say, how much can I pay for this if I pay cash for? They cannot legally, contractually, they cannot charge you less than what they're going to get charged, or they're going to get paid by the insurance company, because the insurance company says, we will never be, beat on price. You have to pay, whatever we pay you, you can't charge someone lower than that, because again, they have their rules with the networks that they built. So that's when this gentleman went to a big chain pharmacy, asked a cash price. They have to charge you a price that's way above normal, it's sort of applicable, so that they don't interfere with these insurance agreements. And then when they went to Food City and they said, use your GoodRx card, well, now we're allowed to use that price through the GoodRx program, because they have this agreement on the back end with these big companies that allow all of this to happen for, again, a significantly discounted price. But at the end of the day, these insurance companies find a way to make money, doesn't matter how you pay for your medicine, somehow, some way, they found a way to get that. And so, so to go into your local mom and pop pharmacy, asking them, what's the best price I can get on this medicine if I didn't use my insurance, they have a little bit more flexibility, and they can tell you, okay, here's how we can get you an affordable price for your medications without having to use some of these discount cards. Although they have their own that are good for the pharmacies, they don't hurt them, that they can use as well.
That's just jaw-dropping to me that using GoodRx, some of these PBMs are still making money off that prescription. That is just eye-opening for me. I had no idea. So that had to be one reason you have your own now. You only deal with small pharmacies, right? So you don't ever go up to a CVS and try to talk with them, right, in your company?
We don't. We haven't. We had access to all the pharmacies in the country. We have what's called a WAP network, where we have this agreement that for all the standard prescriptions, we can charge us a standard price for that. So our members can access any pharmacy in the country. When they go to CVS, Walgreens, Walmart, whichever national pharmacy they would like to, they can still access our program. They just pay the standard cost. Whatever CVS in their agreement says we should charge for that medicine, that's what we charge, and that's what the patient will pay at the pharmacy. When they go to our preferred pharmacy, the incentive is lower cost share, lower copays, and most importantly, we also get to save the employer money when they choose one of our preferred pharmacies in this Cost Plus network.
That is so interesting. Do you deal at all with Medicare drug plans?
We don't. We haven't gotten involved in the government space. There's a lot of regulation there, and you need to have a lot of money in the bank to be able to offer a Medicare plan or work with a Medicare plan. So we're not there yet, but we plan to hopefully showcase how this model can work really well in the employer market, and then find an opportunity to either work with Medicare or Medicaid in the future.
Because really, Medicare patients are the ones that need it the most, I would think.
Yeah.
Of course, being 7 years old, I'm on Medicare myself. Fortunately, I'm not on medications, but I think the seniors are the ones that because they're usually not working and they're on a fixed income. But that's one reason why I will never retire personally. But so this is really jaw-dropping to me about the GoodRx program. So I can kind of correlate this with what hospitals do when you go in the hospital for a procedure or hospitalization. They jack the price up so high, hoping to get a small part of it, that the person that has no insurance or that has a very high deductible is going to just take it. I mean, maybe bankrupt them. I mean, it's unbelievable.
The amount of people that go into medical debt is shocking. And it's not just people who don't have insurance. It's people who have insurance that also are going into medical debt, where it's unbearable for people in, the common American to be able to afford these expenses.
So tell me about your company. And again, I want to print the information for your company at the end of this podcast so people can email your company to see if they might be a good candidate for signing up with that. As a matter of fact, I'm going to definitely look at this myself. We have 50 employees in my little company, but and we insure our workers here. But so how is your company different than, say, a GoodRx, in the fact that you just work with certain pharmacies, or your price? Give me a good little reason why you did this and how you differ from the others.
Yeah, that's a great question. So we are a pharmacy benefit company. You want to think of us more like the opposite of what Express Scripts, Optum, RX, and CVS Caremark do. So we're a pharmacy benefit company, but our model is completely opposite. So we went out and looked at the market and said, whatever the big three are doing, we want to do the complete opposite. So if they're focused on making sure that only branded drugs are available on their formulary when there's a generic available, we're going to make sure the generic's available on our formulary. If they built a network around these large pharmacy network chain stores, we're going to build a network around local mom and pop pharmacies, and make sure people understand transparently the cost of the medication, whether it be a penny, $1, $10, or $100, or $1,000, or $500. We want to make sure people understand this is the cost of the medicine, because the conversation in the country today is, how can we get drugs for cheaper? Well, there's a floor to this price, and we go below that floor, we're going to start having a lot more pharmacies closed, and there's going to be a lot more trouble, because to some extent, it's already happening. And so we need to change the conversation around what's the value of these medications. How, the pharmacy is just one component in your healthcare, and it's a tool to help you live longer, live healthier. and make sure that we get some value out of these medications. So let's have the conversation around value instead of just cost. And that's really our target is go to employers with this network of pharmacies, this model that we build, cost plus, and help them understand that there's a better way to help provide healthcare to their employees. And we're just one option. There's many companies like ours that aren't small pharmacy benefit companies that are out there doing what we do. And we think there need to be more of them because there's so much help that needs there's so much we need to help in healthcare to fix. And so that's what, we're really targeting the employer market. And that's sort of our core program is this cost plus model. And
So
then
cost plus, like you would say like you built a house and your builder does cost plus the cost of materials plus 10% or 15 or whatever for profit. That seems to be very transparent. I like that.
And all of that goes to the pharmacy. So that's the nice thing is now you know exactly what the cost plus is. It's a fixed dollar amount, it's not a percentage with us. And then all of that money goes to the pharmacies. The pharmacy knows exactly what they're going to get paid. And hopefully they're not, and they're not getting paid below the cost of these drugs because we're paying them what they're buying them for. And so that's just an engine or program. That's just contracts that we have. We take that and we go to employers with programs. And then we also have programs that we work with doctor's offices as well, that especially like yours, which are cash pay, direct primary care practices, concierge practices, where we have a membership program where we package this cost plus program and said, for a fixed fee every month, you can get access to over 300 of the most commonly used generics in the country at no cost from our local mom and pop pharmacies, and everything else is cost plus. So you never have to worry about overpaying for a drug because you'll know exactly what you're paying for, and it's exactly what the drug costs plus a fair fee to pay the pharmacy as well. So we have
That is
we're
interesting. So we've got to keep these small pharmacists going. I mean,
Absolutely.
to me, we can't give up to the big chains. It's just be so impersonal and just such a disaster, in my opinion. And so that probably is your goal, is to keep these small pharmacies in business and deliver a quality product
It absolutely
to the patient.
It absolutely is. And to be clear, as a pharmacist, there is nothing bad that I have to say about the good, hardworking pharmacists that work in these chain pharmacies. The real crux of the issue, they don't have the time.
It's
They
not
have
their fault.
policies that they have to follow, and so many patients that they have to take care of that it's just in some instances, it's not safe for them to provide the care that they do, and they do it diligently, and they do it with such great work to take care of all the people that they serve. But that's why you get more personal care, because those pharmacies, the mom and pop, just had more time to spend and take care of their patients.
That's why I did my whole practice, because when I was seeing 40 or 50 patients a day and I was on a computer doing an EMR trying to find a code, it was just so impersonal. In and out, your average visit was 7 minutes. You cannot do quality medicine that way. Now I see 12 to 14 patients a day, spend a lot of time, try to get to the root cause of the problem, which is functional medicine, integrated medicine. But you're right. It's not the pharmacist's fault. It's not the doctor's fault that work in these big groups. They're like a rat on a treadmill. They don't enjoy their job for the most part, especially for primary care doctors, which are the basis of medicine in this country, in any country. So it's not their fault. They just are forced to play in the system that turns out to be bad for them, bad for the patient. I may title this podcast "A Good PBM?" ? Because I always kind of talk bad about the PBM. So it's interesting that you would tell me that you're a small reverse PBM. So, really, when you describe it, that's exactly what you're doing. Because really, the idea of a PBM was good. They were supposed to come in and negotiate better prices for patients.
That's right.
And pharmacies from the industry. And in my opinion, the insurance companies took over. I think out of the one bad guys in healthcare, which is an insurance company, everybody has to have it. Like I tell people, insurance is for disaster. It's not for your everyday cold and what I've found that being a cash only practice, I get great patients. They really want to see me and they expect more. I'm a better doctor because of it. I have to be to compete. And it's just more satisfying. And I don't have to search around. I wouldn't know what a code is. I don't go by codes.
Right.
It's ridiculous. You get paid differently, or you have to specify a 5-digit code to get paid for it. In other words, if you're sinusitis, you come in with a sinus infection. Well, if it's a frontal sinus, you better not put that if it's there
No,
because
wow.
they're going to deny treatment.
Oh, wow.
It's unbelievable the amount of codes they've put on these doctors now. I
Wow.
mean, it's just like 5 times what it was 5 years ago.
Oh,
There's
wow.
actually a code that if you get hit by a meteor, there's a code for that as a doctor. Yeah. If a patient comes to you and they've been hit by a meteor, there's a code for it for you to get paid for that. And listen to this. You have to carry that even further than that. There's a code if you get hit by that meteor in your front yard or in the street.
Oh, my goodness.
Yeah. I
The
mean,
doctor's got to figure this out and code it very specifically, otherwise it creates problems.
that's
And
right.
they'll
They'll
wow.
check. They'll go back and look at your dictation.
Oh,
And
my
if they
goodness.
find out that meteor really hit the patient in the street, not your yard, they won't pay you. They won't say it's not accurate. That's just an extreme example,
Yeah.
but it's definitely true. And that's why doctors are so frustrated.
That's
That's why
true.
my pharmacy friends are so frustrated because most of my pharmacy friends work in independent pharmacies. And they're trying to make a living doing it.
Yep.
It's becoming very tough for them. Like you said, they have to take a loss on some of this stuff.
That's it.
So it's crazy. What do you think a good title for this podcast would be? I may let you name it.
You put me on the spot like this. We've been talking about some parallels in pharmacy and medicine, and I think it should really be, the new way forward in healthcare, or something that shows that it doesn't have to be the way it always has been. The status quo reimagined, or revolutionizing the status quo. Something.
An open discussion between a doctor and a pharmacist as to what's going on with cost
Yeah.
of pharmaceuticals. That's a long title, but it kind of describes it. And I am going to put something about you being a reverse PBM in there. All right. I think you need to be in Washington. My hope is that this new administration brings in some people that really shake things up in a lot of ways.
I agree.
Make things just better for doctors and for patients and for pharmacists.
Exactly.
Any parting words of wisdom about, again, I want all the information.
Sure.
And because I'm really interested in this, because as a doctor, part of my, I think, responsibility to my patient is to guide them in what kind of health insurance they should buy. High deductible, maybe medical savings account type thing, which is what I usually do. But it's my responsibility to help these people because cost is a major factor in healthcare, and compliance is directly related to that. But any parting words of wisdom for people, whether it be doctors, patients, pharmacists?
Yes, absolutely. I think the message is mostly for providers and patients is that you have an advocate that works on your healthcare team, but you probably don't see them as part of your team because you don't see them when you go to your doctor's office. But your pharmacist, you should get to know them, and you should ask all the questions that you possibly can to know most about your medicine, the things you're putting inside your body. You have a great advocate out there that knows a lot about those medicines. So please use those resources. Use that resource, that's your pharmacist, in your community. And like you said, Dr. Rogers, is have a relationship with your local mom and pop pharmacy, even if they can't see you because there's issues with your insurance company and how they deal with the pharmacy. Having that relationship will be great to then say, look, I see Dr. Rogers, he's my doctor, you're my pharmacist. I want you guys to know each other because you're taking care of me as the patient, and make sure that all the providers know they have a healthcare resource out there as well. I know sometimes it's hard to get a hold of pharmacists when you contact the pharmacy, but there is a resource out there on the healthcare team that's willing, able, and really a great resource on the healthcare team to help patients out.
I love it. I do call pharmacists frequently and talk with them, and I'll discuss the case. I have this patient with this weird rash. I need such and such, and they'll compound a medicine for me, or they'll give me advice about interactions with oral medications or injectables. So I rely on the pharmacist a lot.
That's
I
great.
really do. So we work hand in hand. What you said a minute ago, which I may title this podcast, Pharmacy Advocate. I like the way you put that. And we're not only talking about cost, we're talking about better care as well, which is, in the end, all we're there for is the patient. You know, I have a T-shirt that I wear sometimes, and it says, "I work for patients," because I really think that most doctors don't. They work for the insurance company or the big corporation or the hospital group, whatever. But all right, give me a little bit of information about your website. Where can people go to read about this, and maybe if they want to, sign up or talk to their employer about where they can do something like this, what website should they go to?
The best place to reach us would be MakoRx.com. That's MakoRx.com. There's a contact us form on there. You can reach out. We have our company number on there. They can reach out and talk to our frontline team, and they can give you information about how to get in touch with us to get more information. I think that above and all anything, we're here to make sure that we educate the community, the employer community, and everyone associated with them, consultants, and all the healthcare stakeholders around. Here's how pharmacy works. Here's how we can make it better. Now let's all figure out how to work together to solve some of these problems.
I watched a couple of your podcasts. I thought they were excellent. You have some good people on there, and you're very informative, and I like your demeanor. So, Dr. Vinay Patel, thank you so much for being on the show today. People go to MakoRx.com, and let's do another one of these in a few months and see because it changes. Things change.
Yeah,
it's going to be really interesting to see, but I'm very interested in doing more research on your company. And kudos to you for doing something like this. That's very innovative, and I'm into that kind of thing. So, Vinay, thank you so much, and hopefully we'll talk soon, okay?
We will. Thanks again, Dr. Rogers.
Thanks, Vinay. Guys, we'll see you next week. Thank you.